Let's talk about BiPAP. So oxygen, so nasal cannula, the regular nasal cannula. So how much oxygen can we get in a regular nasal cannula, or maximum oxygen that we can give in a regular nasal cannula?
6.
6. Why?
Resistance to flow from the tubing?
Okay, but you can still run whatever you want. If you go 15, 20, it will still run. There's no hole. As long as there's no hole from the tubing that's going from the wall all the way to the nasal cannula, you're good.
All right.
The reason is sinusitis and headache. Because what happens is that you have a large amount of flow, because the catheter is small, and then it's dry oxygen, and it goes in and it dries the secretions here. It fills all the sinuses that are not supposed to be filled with air, with large amounts of flow that will actually make the patient immediately having headache if you go above 6. Some of them feel it, some of them don't. Some of them express it, some of them don't. But the real thing also is sinusitis, because it dries the secretions at the antrum of the maxillary sinus, and that results in sinusitis. So that's the two things. So it's nothing serious here. So if the patient is dying because of lack of oxygen, it's a crime to actually stop at 6 liters per minute. 6 liters per minute this is luxury for ICU patients. Somebody's dying, you gotta give him 6 liters per minute. So what is the FiO2 at 6 liters per minute? The FiO2 is calculated using this calculation here. 21%, that's the amount of oxygen in room air, plus 6 times 3. So each liter gives you 3%. That's rough estimation. So that will give you 21 plus 90 plus 18, that will give you 39%. About. So if you're wondering why everybody has their vents set up at 40%, not here, but in general, people, the most common FiO2 on the vent to start is usually 40%. That's because of this. It's an old myth, It was good when this is the only thing we had, because you can only go to 6 liters per minute, and that gives you about 40%. So that's why I set the vent at 40% to know that the patient will tolerate being extubated when it's ready to be extubated. So let me ask you this. The 6 liters per minute is actually is 100% oxygen, like 6 liters coming from the wall. This is not mixed, it's 100% oxygen. How is it becoming 40%?
Does that have to do with dead space?
No. In training. So as I'm speaking right now, if I'm speaking normal, if I'm breathing normally, what's going to happen is that I'm drawing about 10 to 20 liters per minute flow, the rapidity of the breath flow. So if I want 20 liters per minute, I'll take 6 liters from the nasal cannula, whatever is given, maybe another 2 liters or something that is stored or in my nasal crevices and nasopharynx and all of these things. And then the rest is going to be 21% is coming from air. That's why you have 39% because of entrainment. So that brings me to the next thing. If I'm breathing a little bit faster, I'm now short of breath. I'm doing like this. And I'm pulling in 100 liters per minute because I'm hungry for air. What's going to happen to the FiO2? It's going to drop. So the nasal cannula, if you stay at 6 liters per minute and the patient is in distress, the FiO2 is going to go down. While the patient is in distress, the FiO2 is going to get closer to 21% as opposed to away from 21% because I'm entraining more percentage, right, of the air. So that's the 6 liters per minute. But if you have somebody on a regular nasal cannula and he's in distress, you can actually go to the max. What is the max on the wall?
It's like over 100 and something, right?
150. Right? So I'll show you why. So basically this is your source of oxygen. It goes through This is the knob that you turn oxygen on, and it goes through something called the Thorpe Tube. The Thorpe Tube is the tube that we are using to measure, the flow meter, basically. Inside the Thorpe Tube, or sorry, that's the flow meter. Inside it is the Thorpe Tube, which looks like this. Okay. So inside the Thorpe Tube there is a ball that keeps on rolling, and that ball you can put it here. So as the oxygen is going, if you turn it to 2 liters per minute, the amount of air that it will lift the ball only to here, because there's little escape of the air around the ball. So it really 2 liters. It's very light ball. So it really pull it up to 2 liters as the oxygen is going to the patient. But this will measure as 2 liters. If you want to make it at 6 liters per minute, it will be here, because there's escape of the air around the tube is getting larger and larger as you go, the diameter. So now there's more escape of the air around the ball. So you need 6 liters per minute to keep the ball at this level. If you want 10, it will be here. If you want 15, it will be here. Huh? But above 15, they got tired of it. They said we're not gonna go graduated, the tube all the way to the ceiling. Huh? So we're gonna just play it open at the end. And if you want to keep the ball here, where there's a lot of escape of air around the ball, about 150 liters per minute, or that's at 50 psi, coming from the wall, 50 psi. And that gives you about 150 liters per minute. There's a lot of applications for that. So if you have somebody that is in distress, don't be, until you get the next equipment, don't be hesitant to just put that oxygen all the way up until you can't hear the next person in the room, and you can actually feel it. You put your hand on the oxygen. If you go in an empty room, open the oxygen to 15, feel it and hear it, and go up to 150, which is the max, and you hear it and feel it. Well, this company that made this, or companies that made this, need to be, some of them, or all of them, I think, need to be sued, because they didn't write anything. They didn't explain to anybody the common knowledge that 15 is the max. If you tell a nurse as you're coding somebody or resuscitating somebody, go to the max oxygen, so you're gonna say 15. She's not gonna go 150, because nobody knows. That's the problem. And what's written here, so written up to 15. What's written here? Some of them write flush, and we have a mixture. Some of them write flush here, and some of them write flood. And some of them write nothing. There's nothing written there. It's just that this is flush or flood. So this is important knowledge that you need to keep, because that will fill all the cavities inside the patient's airway, and also come out and will actually make the patient breathe 100% oxygen, and helps with apneic oxygenation, and help oxygenate you also if you're distressed or something. Next, we're going to talk about the venti mask. And the venti mask is the biggest scam in medicine. The idea of the venti mask, using the Bernoulli principle, which is the JET principle, basically, it's a great idea for the lab, but not for the patient. So this is the idea. The venti mask comes with 4 or 5 adapters. Each one has a different size, different color, and each color gives you an FiO2. So this color gives you 40%, this one, all the way to 80%. So it comes from the wall like this, dry oxygen, and it goes through an adapter, that plastic adapter that we talked about. And then from the adapter it goes to the mask. So the adapter has slits opening like this, like longitudinal openings in it, and different sizes of openings. So it's open to air, right? So as you're running 10 liters, all of the calculations, by the way, on a venti mask calculates on 10 liters per minute. So if you run 10 liters per minute, it will go through the central channel of this, like if you will, it looks like this. It will go through that central channel, but all of these holes here, it will, because it's like the jet principle. Something going here, it decreases the pressure outside, so air will go into the same channel, so it will entrain air. By definition, it will entrain air, and the entrainment of air is dependent on two factors. One of them is the amount of flow that you're starting with, and the size of these holes. So that's why they can tell you from 4 even. But that's true only here. The mask is loose. Patient can entrain from here too. Patient effort can affect how much entraining can happen. So for me, why agonize over the red color or the orange color, where I can just increase the flow or decrease the flow with oxygen, and that affects the FiO2 that's going to the patient. And everything is rough estimation. There's nobody that can measure the FiO2 in the patient's nose. We can invent something like that, but it's not necessary, right? You're titrating for effect. Next, we're going to talk about the non-rebreather mask. And some people, there was a movement to call it rebreather mask. I don't know why you call it rebreather mask. I don't know. I think it's non-rebreather makes more sense, but it doesn't matter, rebreather or non-rebreather. The idea is that you are rebreathing. It's not rebreathing. It's actually you're pulling in from a depot of oxygen, or some collection of oxygen, which is the bag. So you're not rebreathing it. You're just breathing from oxygen source. It has nothing to do with rebreathing or non-rebreathing. But anyway, it goes like this. So basically, oxygen goes like this, goes to the mask, and goes also to a bag. So it goes here and goes here. And there's a one-way valve here that will allow the patient to, if he wants to pull, it will come from the bag, but nothing of the exhalation can go into the bag, right? The mask is a little bit more fit, a little bit more tight to the face, and also instead of the holes that this mask have, it has like a collection of holes, so like this. So the mask looks like this. Like openings, small openings like this, and small openings like this here, instead of the one big hole. And one of them at least has a one-way valve on it. Like a little diaphragm, a little disc that will open up as the patient is exhaling, and then as the patient is sucking in, it will close. So the most of the air will come from here. Like this, that disc, small disc like this will just suck in, so prevents the amount of entraining that happened, but so most of the entraining happened from here. But that doesn't say 100%. Still, my nose is big, it will go from here, it will go, stuff like that. So it gets you close to 80% or so, the non-rebreather mask. And all of the calculations also are made at 10 liters per minute. You can go higher than that. So if you have a non-rebreather mask and you run it at 150 liters per minute, that's an amazing amount of oxygen. You're probably very, very close to 100%. Now, let's talk about the high flow nasal cannula. And here in this hospital, we differentiate between high flow nasal cannula and the heated wire high flow nasal cannula, because we have the two types. If you don't have the two types, it's going to be a problem. So the high flow nasal cannula, some smart guy came in and said, so what's the problem again you told me about the nasal cannula causing whatever? Oh, causing dryness of the secretion and causing sinusitis? Oh, okay, so why don't we run it through water? So they have this aqua pack that they put it in, and this is the flow meter here with the knob. And just oxygen goes from here, and then it comes out from the top here, bubbles through water, come out from the top, oxygen, humidified oxygen, that goes through the patient's nose, and that actually makes it humidified, so they can go up to 15 liters per minute. So that was an amazing development here in this hospital, because we could now leave patients on the floor up to 15 liters per minute. It really helped us a lot, especially during COVID and everything. People who stay in the floor until they reach 15, if they go higher than 15, then we'll take them to the ICU, depending obviously on their work of breathing and stuff like that. So that's your the high flow nasal cannula. It's a little bit bigger, you know, in size a little bit. Okay, so
What percentage does that give you at?
well, nobody knows. I mean, if you do the calculation using the 3 mLs, the 3% per ml per liter per minute, 15 times 3, that'll give you 45 plus 21, about 65%. Yeah, so we can titrate patients on that. The FDA, I think the CDC made a mistake during the COVID, and they said you can't use the high flow nasal cannula for COVID patients. So a lot of hospitals could not use the 15 liters per minute. So as the oximizer also, the oximizer is a device that will it's a nasal cannula that has like almost like a bag like this, and basically you know, it keeps some oxygen that is stored in the bag, and then you can use the oximizer to use the nasal cannula to suck from the bag, like similar to this a little bit. But these two, this is we know its name, but hospitals who have high flow nasal cannula, they got a recommendation from the CDC saying you can't use high flow nasal cannula. What they mean is the heated wire high flow nasal cannula, not the high flow nasal cannula, because as we talked before, normal patients who breathe normally, they breathe about 10 to 20 liters per minute. So if I'm giving them 15 liters per minute, the amount of dispersion of this outside their nose is going to be limited. It's not going to be more than 6 feet.
Are there any structural differences between the high flow nasal cannula itself and the regular nasal cannula? Like
Just a little bit
larger
bigger.
tube? Okay.
It's green color, but it's bigger. It doesn't have to be bigger, by the way, but bigger just makes it a little bit more comfortable. So the flow is a little bit, it doesn't hurt the patient. Now the heated wire high flow nasal cannula is an invention that I think should have received the Nobel Prize, because I can't tell you how many patients we, throughout all the influenza epidemics throughout the years, that we prevented them from getting intubated because of this. Influenza damages the lung, as you know, like COVID, right? And the damage just takes time. It just takes time to resolve, especially young people. They need to be under. So imagine if we intubate these people for 4 weeks and 6 weeks and stuff like that, they'll be trached. And the complications are unbelievable, and it becomes like a sad story at the end. But most of these people, we would just keep them on a heated wire high flow nasal cannula, and they just cruise, right? But they're frustrated because they're in rehab for 2 months. But it really helped a lot. So this invention here, you can actually hook it up to the regular flow meter. So oxygen